disorders. This is Claire Francomano and Laura Bloom, and we're here today to talk about the 2017 International EDS classification. This is really a landmark day in the history of the Ehlers-Danlos syndromes. The American Journal of Medical Genetics is publishing 18 articles today that summarize the current state of knowledge about the Ehlers-Danlos syndromes and related disorders. And it's really a great pleasure and a privilege today to be able to represent the international consortium to discuss the information that's been presented in these 18 articles in the American Journal.
Just testing that everybody can now see the screen. There we go. Welcome, everybody.
Okay, so the classification of the Ehlers-Danlos syndromes has not really been addressed since 1997, when the Villefranche nosology was put forward. This was published in a paper by Byton et al. In the American Journal of Medical Genetics in 1998. And at that time, there were 6 major types. You can see them listed on the slide here. They included the classical type, the hypermobility type, the vascular type, kyphoscoliosis, arthrochalasia, and dermatosparaxis types. And even back in 1998, the molecular cause for 5 of these disorders were known, but the hypermobility type was not then and is still not known. So it was really more than time for a revision of the Ehlers-Danlos syndrome's classification. This whole process began in Ghent in 2012. There was an international meeting sponsored by Dr. Francisca Malfate and Dr. Anne de Pape in 2012 in Ghent. There was another meeting in Paris in 2013 and in Glasgow in 2015. And the process really got a huge boost when the Ehlers-Danlos National Foundation, which was the charity name at that time, and EDS UK came on board and committed substantial resources to putting forward an international symposium in New York in May of 2016. And the work that I'm going to present to you today is the outcome of that enormous effort that went into developing the symposium in New York and then the subsequent effort to develop these papers that are being published today in the American Journal of Medical Genetics. We anticipate that there will be another meeting in Ghent in 2018, at which time we'll be able to review what has happened since the implementation of these new diagnostic criteria and the new classification. And certainly we expect that this will be under revision at that time. The goal of the Ehlers-Danlos Syndrome Symposium in May in New York were 3. We were to build a revised nosology or classification that defines the diagnostic criteria, define new Ehlers-Danlos syndrome types where necessary, and to begin the process by which management and care guidelines are being developed for each Ehlers-Danlos syndrome subtype. And there were several committees and working groups that were set up to spearhead this process. The steering committee consisted of the chairs of the 4 committee types. So there was a classical committee, which I had the privilege to chair. Brad Tinkle chaired the hypermobility committee. Peter Byers chaired the vascular committee. And Francisca Malfate chaired the committee that considered all of the rarer types of Ehlers-Danlos syndrome. And then there were a number of working groups looking at wide range of different issues related to the Ehlers-Danlos syndromes, and they are listed here on this slide. So the working groups were designed to look at issues related to comorbidities and different organ system involvement in the various types of Ehlers-Danlos syndrome. And as a result of these deliberations, there is a new classification of the Ehlers-Danlos syndrome types. And the list is on the slide at this time. It starts with the classical type of Ehlers-Danlos syndrome, which for some reason is not appearing in the very top of the table, and then the classical like Ehlers-Danlos syndrome, which is autosomal recessive. The three major types, which I'm going to discuss today, are the classical type, the vascular type, and the hypermobile type of Ehlers-Danlos syndrome. We'll start with the classical type of Ehlers-Danlos syndrome, which we will abbreviate lowercase c, capital EDS. The major criteria for this condition are skin hyperextensibility and atrophic scarring. And it should be pointed out that the skin hyperextensibility in the classical type of EDS is extreme. And then the joint hypermobility is the second major criteria. The minor diagnostic criteria include easy bruising, soft, doughy skin, skin fragility, which may result in traumatic splitting, molluscoid pseudotumors, subcutaneous spheroids, hernia or history thereof, epicanthal folds, the complications of joint hypermobility, and a family history of a first-degree relative who meets the clinical criteria. So the committee's recommendation for establishing a clinical diagnosis of classical Ehlers-Danlos syndrome is that a person should have major criteria 1, which is the skin hyperextensibility and atrophic scarring, plus either the joint hypermobility or 3 of the 8 major criteria. The committee felt strongly that confirmatory analysis is recommended for any patient meeting the recommended clinical criteria. So molecular analysis of the COL5A1 and COL5A2 genes identifies a causal mutation in more than 90% of the patients, and this should be used as the standard confirmatory test. In some situations, genetic testing may not be available, and in that situation, electron microscopy findings of collagen flowers on skin biopsy can support the clinical diagnosis. The absence of these confirmatory findings does not exclude the diagnosis, but alternative diagnoses should be considered in the absence of type 5 collagen gene mutation or electron microscopy findings. Moving on to the vascular type of Ehlers-Danlos syndrome. The major criteria include a family history of vascular Ehlers-Danlos syndrome with a documented causative variant in COL3A1, arterial rupture at a young age, spontaneous sigmoid colon perforation in the absence of known diverticular disease or other bowel pathology, uterine rupture during the 3rd trimester in the absence of a previous C-section, and/or severe peripartum perineum tears, and the presence of a carotid cavernous sinus fistula in the absence of trauma. There are numerous minor criteria. I'll just read through them briefly. These include bruising unrelated to identified trauma, thin, translucent skin with increased venous visibility, characteristic facial appearance, spontaneous pneumothorax, acrogyria, or the appearance of an aged appearance at an unusually young age, talipes equinovarus, or club feet, congenital hip dislocation, hypermobility of the small joints, ruptures of the tendon or muscle, keratoconus, gingival recession and gingival fragility, and early onset varicose veins. The Committee for Vascular Ehlers-Danlos Syndrome suggested the following minimal criteria: the family history of the disorder, the arterial rupture or dissection in individuals under 40 years of age, unexplained sigmoid colon rupture, and spontaneous pneumothorax. And it was felt that in the presence of other features consistent with vascular EDS, all of these, or any of them, should lead to diagnostic studies to determine if the individual has vascular Ehlers-Danlos syndrome. And testing for vascular EDS should also be considered in the presence of a combination of the other minor clinical features listed on the previous slide. The diagnosis of vascular EDS rests on the identification of a causative variant in one allele or one copy of the COL3A1 gene. Moving on to the hypermobile type of EDS, which we are abbreviating lowercase h, capital EDS. These new criteria were designed to emphasize the syndromic nature of this condition, to reduce clinical heterogeneity, and to facilitate research into the underlying cause or causes of the condition. And it is certainly expected that further clinical experience and research will lead to revision of these criteria with time. The 1997 criteria for the hypermobility type of EDS, which is what it was called by the Villefranche Committee, where there were major criteria including skin involvement with hyperextensibility and or smooth velvety skin, and generalized joint hypermobility. The minor criteria listed at that time included recurring joint dislocations, chronic joint or limb pain, and a positive family history. The Beighton publication in 1998 did not give very explicit recommendations as to how these major and minor criteria were to be applied in the diagnosis of the hypermobility type. The presence of one or both of the major criteria were considered to be necessary for a clinical diagnosis, but when you look at it, that meant that a person with skin involvement only, which could just be smooth, velvety skin or hyperextensible skin, could be diagnosed with the hypermobility type of Ehlers-Danlos syndrome. So it was strongly felt that a new set of criteria were necessary to homogenize the clinical diagnosis for this condition. So the committee really spent an enormous amount of time thinking about this and weighing different options. And what they've come up with is that the clinical diagnosis of hypermobile EDS requires the presence of 3 new criteria. So we're calling these criteria 1, 2, and 3. Criterion 1 is generalized joint hypermobility, abbreviated GJH. And the main tool that we use to assess for generalized joint hypermobility is the Beighton score, which is the same Beighton score we've always been using. It's a 9-point scale to assess hypermobility. And new cutoffs have now been recommended for the definition of generalized joint hypermobility using the Beighton scale. So for prepubertal children and adolescents, a score of greater than or equal to 6. For men and women, post-puberty and up to age 50, a score of greater than or equal to 5. And for men and women older than age 50, a score of greater than or equal to 4. The committee also felt that if the Beighton score is 1 point below the cutoff, and the 5-point questionnaire regarding joint hypermobility, which I'll describe to you in a minute, if that is positive with at least 2 positive items, a diagnosis of generalized joint hypermobility may be made. So the 5-point questionnaire asks the following questions. Can you now, or could you ever, place your hands flat on the floor without bending your knees? Can you now, or could you ever, bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And finally, do you consider yourself to be double jointed? So just to reiterate, if a person has 2 positive answers, 2 affirmative answers to this 5-point questionnaire, and their Beighton score is 1 point below the cutoff, we can establish a diagnosis of generalized joint hypermobility. Okay, criterion 2. We need 2 or more of the following features. Stay with me now, this is going to get a little complicated. So we have A and B, B and C, or A and C to meet criterion 2. And the features are: A is systemic manifestations of a more generalized connective tissue disorder, B is a positive family history, and C is musculoskeletal complications. And I'm going to describe in detail what the requirements are to meet each of those features. So for feature A, at least 5 of the following features must be present. And these are continued on the next slide. So there's 2 slides with systemic manifestations. They include unusually soft or velvety skin, mild skin hyperextensibility, unexplained stretch marks without a history of significant weight change, bilateral piezogenic papules of the heel, those are those little bumps that pop up when you stand on your heels, recurrent or multiple abdominal hernias, atrophic scarring involving at least 2 sites, and without the formation of the typical scars that we see in the classical type of Ehlers-Danlos syndrome. Pelvic floor, rectal, and or uterine prolapse in children, men, or women who have never had children, without a history of morbid obesity or an other known predisposing medical condition. Dental crowding with a high or narrow palate, arachnodactyly, which means long, thin fingers, as defined by 1 or more of the following: a positive wrist sign and a positive thumb sign. The arm span to height ratio greater than 1.05, mitral valve prolapse, mild or greater, based on strict echocardiographic criteria. And finally, an aortic root dilatation with a Z-score greater than +2. So to meet feature A, which is systemic manifestation of a more generalized connective tissue disorder, we need 5 or more of this list of systemic features. Feature B is relatively easy. This we can get easily. Positive family history, one or more first-degree relatives independently meeting the diagnostic criteria for hypermobile EDS. And feature C is the musculoskeletal complications, so one of the following: either musculoskeletal pain in 2 or more limbs, recurring daily for at least 3 months, chronic widespread pain for more or equal to 3 months, and recurrent joint dislocations or frank joint instability in the absence of trauma. This may either be 3 or more atraumatic dislocations in the same joint, or 2 or more atraumatic dislocations in 2 different joints occurring at different times. Or B would be medical confirmation of joint instability at 2 or more sites unrelated to trauma. So if you have one of these 3 issues, that would meet the criteria for musculoskeletal complications and thereby meeting feature C. Now for criterion 3, all of these need to be met. These are basically exclusionary criteria. So we need the absence of unusual skin fragility, which should prompt consideration of other types of Ehlers-Danlos syndrome. Unusual skin fragility will typically not be a feature of the hypermobile type of Ehlers-Danlos syndrome. Next, it's very important that we exclude other heritable and acquired connective tissue disorders, including autoimmune rheumatologic conditions. Now, we know that people who have the hypermobile type of Ehlers-Danlos syndrome may also have some of the autoimmune rheumatologic conditions, but in patients with an acquired or autoimmune connective tissue disorder, the additional diagnosis of hypermobile EDS requires meeting both features A and B of criterion 2. We can't use the chronic pain feature because that may be related to the autoimmune or acquired connective tissue disorder. So to establish the diagnosis of hypermobile Ehlers-Danlos syndrome in the presence of an acquired or autoimmune connective tissue disorder, we need both features A and B for criterion 2. And finally, we want to be sure that we exclude any alternative diagnoses that may also include joint hypermobility by causing hypotonia or muscle weakness and or connective tissue laxity. So basically, we just want to be sure that we've excluded all other possible diagnoses in establishing the diagnosis of hypermobile Ehlers-Danlos syndrome. When we think about a syndrome, the definition is a pattern of anomalies, at least one of which is morphologic and known or thought to be causally related. And the presence of joint hypermobility in combination with secondary musculoskeletal anomalies alone does not really suffice for delineation of a genetic syndrome. And joint hypermobility may occur independently or in the context of multiple different genetic disorders. We see this if you look at OMIM for joint hypermobility, I think there are over 160 genetic diagnoses that come up with joint hypermobility. So it's really very important for us to establish a classification for joint hypermobility. And Dr. Castori and his colleagues and Dr. Tinkle and his colleagues have labored very, very hard to think about a way in which we can have a framework for thinking about joint hypermobility and the hypermobile type of Ehlers-Danlos syndrome. So Dr. Castori and his colleagues have laid out this idea of thinking about joint hypermobility along a spectrum. And when we think about it, we can think about people who have asymptomatic joint hypermobility. There are people who have very lax joints, but they don't bother them at all. They go about their business. They may be able to do some tricks. They may never even come to attention. And that joint hypermobility may be localized, just in one or a few joints. It may be generalized, meeting the Beighton criteria for joint hypermobility, generalized joint hypermobility, or it may be limited to the peripheral joints, which are the joints in the small joints of the fingers and the toes in the hands and feet. So that's one classification of people with joint hypermobility who do not suffer from any symptoms related to that joint hypermobility. Then there are people with well-defined syndromes with joint hypermobility. And this will include the various types of Ehlers-Danlos syndrome, and it will also include many other genetic disorders which need to be considered when a person presents to the physician, the diagnosing physician, for evaluation of joint hypermobility. And finally, there are going to be many individuals who have symptomatic joint hypermobility, but who do not meet the diagnostic criteria for a specific syndrome. And to include those people in our diagnostic classification, we have now put forward the idea of the hypermobility spectrum disorders. And this table summarizes the spectrum of joint hypermobility and the relationship to the Beighton score and musculoskeletal involvement. So we may have asymptomatic generalized joint hypermobility in which the Beighton score will be positive for the person's age, but the musculoskeletal involvement will be absent. In asymptomatic peripheral joint hypermobility, the Beighton score will usually be negative because the peripheral joint hypermobility is limited to the hands and feet. And in asymptomatic localized joint hypermobility, the Beighton score will also be negative because the joint hypermobility is limited to one or just a few joints. Now, in generalized hypermobility spectrum disorder, the Beighton score is positive and musculoskeletal involvement is positive. So these are people who are symptomatic. They may experience pain. They may experience dislocations, subluxations. They may have many of the comorbidities that we now associate with the hypermobile type of Ehlers-Danlos syndrome. But they may not meet the diagnostic criteria for hypermobile EDS. And therefore, we will call them generalized hypermobility spectrum disorder. Peripheral hypermobility spectrum disorder are people who are symptomatic. The Beighton score may be negative, but the musculoskeletal involvement is positive. The joint hypermobility in these people will be limited to hands or feet, but they may be suffering from pain, from subluxations, from dislocations, from all of the things which may impact on life. So we now have a label, a name to provide to these people. This is peripheral hypermobility spectrum disorder. Similarly, for the localized hypermobility spectrum disorder, because the joint hypermobility is limited to single joints or body parts or just a few joints or body parts, the Beighton score will be negative, but that musculoskeletal involvement is there. These are symptomatic people. And so we call them the localized hypermobility spectrum disorder. And the important thing to remember is that we must address the symptoms as they are presented, and that management of those symptoms is our major goal. HHSD is the term that we're using for the historical presence of hypermobility. A person may not be hypermobile now, but may have been hypermobile in the past. So in these people, the Beighton score may be negative now on exam, might have been positive previously, but still they're experiencing the musculoskeletal involvement that impacts the quality of life. And so they fit into this hypermobility spectrum disorder. And then in hypermobile Ehlers-Danlos syndrome, the Beighton score is positive. Musculoskeletal involvement may or may not be present according to the diagnostic criteria I presented earlier. So we have now a spectrum of joint hypermobility that ranges from asymptomatic through symptomatic all the way to the hypermobility type of Ehlers-Danlos syndrome. Now, two questions that have come up a lot since these diagnostic criteria have been known and discussed is why were comorbidities not included in the hypermobility EDS diagnostic criteria? This is one question that's come up quite a bit. And I would say that we really don't know enough yet about the relationship and causation between the various comorbidities and hypermobile Ehlers-Danlos syndrome or any of the other types. So we really hope that further research will enable us to establish these causative relationships between the comorbidities and the many different types of Ehlers-Danlos syndrome. And another thing people have been very concerned about is that they say, I don't know if I meet all those diagnostic criteria. Will my diagnosis be changed? And I would say to that, unless you have a reason to seek a change in diagnosis, there's no reason to do that at this time. If you're interested in seeing whether you meet the more stringent criteria, excuse me, for hypermobile EDS, you may certainly speak with the physician who made your diagnosis to see whether you meet the new criteria. To me, the most important thing to remember is that treatment and management are paramount. Whatever symptoms you're experiencing should be addressed regardless of your diagnosis. So thank you all for your attention. I'm going to turn the webinar over to Laura Bloom, who's going to be discussing the role of the Ehlers-Danlos Society moving forward.
Thank you. Thank you so much to Claire for going through the new classification with us. And I'm now going to talk to you about what we will do as your charity going forward. So I'd like us to remember why all this work has been done. Apart from the incredible individuals and hubs of expertise dotted around the world, EDS has been one of the most neglected disorders in modern medicine. As patients, we're not listened to, respected, validated, managed, diagnosed effectively, or given a good chance to live an improved quality of life. We were trying to fix something that was broken, and with these new official criteria that now replace the Villefranche criteria, we can do that. So what will the society do to spread this new classification? We plan to start on updating the ICD-10 codes that insurance companies use. Currently, there is only one for all the types of EDS, so it needed to be updated anyway to reflect the different types. And now we need to introduce the HSDs. Until then, we should having an HSD diagnosis will mean that you won't get covered by your insurance. Clinicians are able to use symptom-specific codes to get you treated, and many of them use this currently anyway, so we do not foresee that these changes will make it harder to get anything covered. Quite the opposite. These changes will now enable us to put these right. We also now plan to work with the WHO, which is the World Health Organization, to get these guidelines internationally accepted. By forming our international consortium and having collaborative research and agreement, we are now much closer to this being a reality. The Society are also proud to announce that we're now an associate member of Rare Diseases International, and I plan to go to their next conference in Barcelona in June, and we hope that this relationship will help us further in spreading awareness. Now that we have a newly revised nosology, we can also continue our efforts to get NICE guidelines. For those outside of the UK, this is the National Institute for Health and Care Excellence guidelines in the UK, and these are used when anybody is following a diagnostic pathway. And these are essential to improve the NHS treatment for those suffering in the UK, and it really is high on our list of priorities. And I am pleased to say that there is progress being made. And when I have more information that I can share, we will do with all of you. The Society and consortium members will also continue to attend conferences to educate and talk about the new criteria. Dr. Alan Hakim, a member of our medical and scientific board and the consortium, has organised a session at the upcoming British Society of Rheumatologists conference to discuss the work, and I am excited for the opportunity to help present this to that audience. And the Society will also continue to talk at events with other umbrella organisations such as Dysautonomia International, EDS, Rare Diseases International and Rare Diseases UK, and so on. We also aim to expand our opportunities to encourage student exchange amongst the clinics and specialists that we have on the consortium, so that we can educate the medical professionals of the future. Question that's come up a lot is, will the Society now support those with HSDs? The answer is absolutely. We will support all those with the Ehlers-Danlos syndromes and related disorders such as HSD, mast cell, POTS, and so on. This publication will not change that. You will all still be in our focus when we are planning research, events, and conferences. So how can you help? Firstly, it starts with us. You need to be the change that you want to see in the world. You need to use the correct terminology. We provided a table on our frequently asked questions, and we're really asking that people use the right terminology. They're very small changes, but the implications of using the wrong ones will not help us achieve consistency globally. So it used to be Ehlers-Danlos syndrome. We are now needing to recognize all the different types, and it's the Ehlers-Danlos syndromes. It was hypermobility EDS, it's now hypermobile EDS. It was capitals HEDS, VEDS, CEDS, etc. It's now lowercase h, v, or c, and capitalized EDS. And it was joint hypermobility syndrome, or benign hypermobility syndrome, or hypermobility syndrome. These are no longer going to be used, and this is now going to be the new criteria for the hypermobility spectrum disorders. And the most important one that even some clinicians are still using, even though they were stopped in 1997, people are still using type 3, type 4, etc. Please do not use these descriptors. Use the wording and the names and the abbreviations as we mentioned. This will really help us to achieve that consistency. I'd like everyone to keep in mind this: together we can dazzle. In the weeks, months and days that follow this new classification, because I was very disappointed by the social media reaction when we first posted our FAQs. Unfortunately, due to the information being leaked, we were forced to put something out there earlier than we had planned to. It wasn't the process or the order of things that we would have liked, but we had to respond to the fear and the questions that were arising. Let's remember we are a small community. The charity has many people just like you working for it, and this effort was made possible by clinicians and patient experts to help improve our lives. I ask for you all to please go forward with positivity and support for each other, and help us as your charity vested in everyone's best interests. What else can you do? You can print out the papers, take them to your doctors and share them as far and wide as you can. This wasn't done for the Society. This was done for every national charity and organisation, and this was done for every single patient and family living wherever you are in the world. The entire supplement will be free to download via our site for 3 months, and the classification paper will be free to download long term. After the 3-month period, the papers will individually be available on our website for free, so there will never be a time you cannot access this information with no charge. In the next few weeks, we will also be uploading lay versions of all the papers for you to read if you find the original material too complicated. And we are also currently looking for ways to have it translated. Another question that keeps coming up, is it rare? I'm confused. As you know, the zebra is associated with our community. And the reason for this is because medical students have been taught for decades, when you hear hoofbeats behind you, don't expect to see a zebra. In other words, look for the more common and usual, not the surprising diagnosis. But many of us spend years pursuing a diagnosis for disorders that aren't well known or aren't expected in someone who looks normal or too young or old to have so many problems, or even too rare for anybody to be diagnosed with it. So the zebra has become our symbol. Sometimes when you hear hoofbeats, it really is a zebra. Ehlers-Danlos syndromes are unexpected because they are rare, and the hypermobile spectrum disorders are common, but unexpected because they remain misdiagnosed or underdiagnosed. When you see a zebra, you know it's a zebra. But no two zebras have identical stripes. Just as no two people with Ehlers-Danlos syndromes or HSD are identical. We have different symptoms, different types, different experiences, and we're all working towards a time when medical professionals immediately recognize someone with EDS or HSD. And as everyone knows, my favorite part of being a zebra is that a group of zebras is called a dazzle. And we are a community of individual zebras. We are stronger together and we dazzle. But in reality, our community probably look a little more like this. All of the EDS types currently fall under the rare category, but we know that those living with HSDs are much more common. We cannot really state true prevalence figures in either group because we need to do more epidemiological studies and finally prove how common and rare these disorders really are. Another question that's come up is, will you be changing the name of the charity? The answer is no. We only just launched in May, and we really feel that our branding, messaging, and mission reflect our support and focus on EDS and all the related disorders that now include the hypermobility spectrum disorders. We have updated our website with this in mind. Some of the changes will be on there today, and some of them will take the next few weeks to come through, so please be patient with us. We hope that we have addressed some of your concerns. We're now going to switch over and start to begin answering some of your questions. Okay, let's have a look at some of these questions that are coming through. Okay. Is this publication official? Does it replace the old publications like that of Villefranche or Berlin? And is this what the doctors will be using to diagnose the EDS form? So I think the answer to that is yes. This is official. This is internationally agreed upon. And this will be replacing Villefranche, the Brighton criteria that was released, and Berlin. So yes, this is official. Another question that's come in from Chloe. In selective countries and states around the world, EDS is considered a bleeding disorder. Is it known most bleeding disorders patients have EDS or a family history of EDS? I'll pass that over to Claire.
So there is a subset of patients with Ehlers-Danlos syndrome, one of the types of Ehlers-Danlos syndrome, who have bleeding disorders. The exact nature of that bleeding disorder has not really been very well characterized, but certainly if people have joint hypermobility and a tendency for bleeding, evaluation by a hematologic expert would be warranted for sure.
Thank you. How can tethered cord be diagnosed in EDS type 3 patients? Hypermobile EDS.
So yes, that would be the hypermobile type of Ehlers-Danlos syndrome. There are a number of questions that we use to ascertain whether a person is likely to have a tethered cord. This is a little out of the scope of our intent for this webinar at this time. But I would say that I'd like to refer you to the neurologic paper in the journal, which will be available today, and there's quite an extensive discussion on that subject.
Thank you. And this is from Cheryl. What is the recommendation for hypermobile EDS in terms of how often they should see cardiologists if there are no known heart issues? Are there any now agreed standards of what they should do in terms of regularly seeking out care?
So in terms of the cardiology, if a person has had an echocardiogram as an adult and that echocardiogram has been normal, there have been several publications now suggesting that follow-up can be pushed forward to every 5 years. In fact, one publication suggests that no further echocardiogram evaluation is necessary. So I would make that decision in conjunction with your cardiologist. But certainly the annual echocardiograms that we used to do, we have a pretty good sense that those are no longer necessary.
Thank you. Will the new classification, this is from Evie, will the new classification help find the hypermobile gene?
I think there's a good chance that it will, because if we take a group of people who meet these much more stringent diagnostic criteria for hypermobile Ehlers-Danlos syndrome, we'll have a much more homogeneous group of people with which to look for the gene. I think that one of the problems we've had so far is that we've had a very heterogeneous group of people, because they ranged all the way from the asymptomatic generalized joint hypermobility to the most severe, severely affected and symptomatic people. And they were not very rigidly defined on a clinical basis. And it may be that that's one of the things that's contributing to the challenge that we've had in identifying the molecular cause or causes.
And I'd also like to add at this point that, as we have mentioned previously, the Ehlers-Danlos Society are working very hard with the consortium to build an international registry. And we believe that we're making this incredibly detailed and looking at lots of different aspects, covering all the different forms. And we really believe that this registry will lead us to finding the gene, or at least give us pathways to doing that. So that's the most important thing that we are now doing. Now that we have the knowledge and the criteria from this work, we can now go about building this registry and really learning much more about this, proving how many people are living with it. And the thing that we are lacking completely is evidence, and that's what this registry will help provide us with. Question from Glenda. There have been different definitions of dislocation versus subluxations. Can you please define a dislocation?
So I'm a geneticist, not an orthopedist, but I would say my understanding of a dislocation is when the joint is completely separated. For example, if the shoulder is completely out of joint. It's a subluxation if it's only partially out of joint. Dislocations are typically much more difficult to replace, and the subluxations, more often people will be able to manipulate them back into location. So there may be a more precise definition from my orthopedic colleagues, and I'll look forward to getting that to you if we hear from them about that.
Thank you. Will other doctors, apart from rheumatologists and geneticists, be able to make a diagnosis of hypermobile EDS or HSDs based on the new criteria? I'll answer that by saying yes, and Claire can add anything. But the reason we've done this is because we want to make it much, much easier across all disciplines for someone to walk into their office and for them to be able to use this criteria and diagnose it effectively and reliably. There were too many geneticists in the US and too many rheumatologists and geneticists in the UK and Europe being, heavily, lots and lots of waiting lists from people that could only seek a diagnosis from these people. Going forward, we want to relieve that pressure and make this much, much easier for anyone to get a diagnosis, A, no matter where you live in the world, and B, no matter what specialist you go and see.
Yeah. As I was thinking about this last night, I was thinking we really should develop a checklist that's a simple piece of paper that people can bring to their physicians. That sort of, we can go through the criteria very easily and check off yes, no, and then do the calculation.
Mm-hmm.
And eventually we may actually even be able to develop an app that enables us to do that.
I mean, again, going back, I don't think people realize the enormous impact that this publication is now going to bring, because it's been 20 years since we've been able to have this kind of thing, to develop checklists, to develop apps, to develop the ability for all of this to happen. So now we have this. It's like we can now move forward and really start to make this easier for everyone, for patients and clinicians alike. So people are worried, but really they don't see the incredible possibilities that are now going to come out of this work. If it's just been individuals doing their best to make this easier, Rodney Graham steering the process with the Brighton criteria that a lot of doctors use, which is now no longer going to be used because we have this new criteria. A lot of people weren't using that. They were using the old Villefranche. It just was a very mixed match, incohesive, world that we were living in, that we really hope this will now help to order and fix. So I think we addressed this in the slides, but for anyone who's joining us that wasn't there again and would like to reiterate it again, Letty and a few other people have asked, if I was diagnosed in the past with hypermobile EDS, does this new classification mean I lose the diagnosis? No. No one is saying you need to be re-diagnosed. You do not need to lose anything. And also change your mindset to losing. Switch. It may be a switched diagnosis. If you do apply to research projects, or if you do go and visit your clinician to be reclassified, then potentially they will then say that you may have HSD rather than hypermobile EDS. And that's okay. That's not losing anything. It's gaining something that might actually help you get more management and care, because that's what's critical here. We need to ensure that people are being managed, treated, validated, and diagnosed. And we had to change things to ensure that happens. So no one is losing anything. So I hope that covers a lot of questions. One question that's come in here. This is from Orla, given that hypermobility naturally decreases with age, as with secondary conditions, are you suggesting that these individuals will no longer be considered hypermobile EDS and they will then move into the HSD category, which is not believed to be a connective tissue disorder? I'll pass that over to Claire.
Okay, so two things about that. I think the decrease of hypermobility with age is considered in the definition of the Brighton score and the Brighton cutoff with different ages. So the committee recommended that a Brighton cutoff of 4 or more be applied to people over age 50. And then with regard to this consideration of a connective tissue disorder, I think the hypermobility spectrum disorders, we still have a lot to learn about the causation. So there are going to be genetic studies looking at patients with those diagnoses. Some people will have hypermobility spectrum disorder because of other causes. But I think many of the people with hypermobility spectrum disorders will represent hereditary connective tissue disorders as well. So we still have a lot to learn about that.
Great. We lost everyone from Facebook, so I'm just getting everyone back there.
Okay.
There we go. So hopefully everyone on Facebook is joining us again now. How will we avoid, this is from Mary, how will we avoid further confusion by physicians with this spectrum table and avoid conversion disorder that so many are diagnosed with?
This is a challenge. I think it's important to recognize the comorbidities, the very many comorbidities that are associated both with the Ehlers-Danlos syndromes and with the hypermobility spectrum disorders. And one of the most important things we can do with these publications is to establish that there is a bona fide relationship between gastrointestinal disorders, allergies, mast cell disorder, so many different issues that are associated with the Ehlers-Danlos syndromes and with the hypermobility spectrum disorders. So the fact that a person has a diagnosis of hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder does not change the association of these various comorbidities. And if physicians are willing to look and listen and learn, they will know that these things are genuinely real and people need to be taken very seriously and treated appropriately for them.
Okay, thank you. So when adding in the historical diagnosis, does that mean that someone who is diagnosed with hypermobile EDS may now be downgraded to HSD as they age and become less hypermobile? So firstly, nothing is downgraded. It's a different diagnosis. It's not less than. That's very, very important for everybody to understand. It is not less than, it is equal, it is just different. I'll let Claire cover the changes with age.
So I believe if somebody's diagnosed with the hypermobile type of Ehlers-Danlos syndrome and meets the diagnostic criteria for hypermobile EDS, say when they're 35 or 40, and then becomes less hypermobile as they age, personally, I would not change the diagnosis in their older years.
Great, thank you. We lost our Facebook group again, so I'm going to just go live with them. At the moment, our signal is apparently not strong enough, so we'll keep an eye on that. Someone has asked at this time. So Glenda has asked, what do you mean at this time? Does that mean at some point we will be required to be re-evaluated? Also, isn't there a concern that doctors may begin to question if we were diagnosed by the old criteria or new criteria and then not take a prior diagnosis seriously? The point of this is that everyone will take any diagnosis seriously. There were doctors not taking a hypermobile EDS diagnosis seriously anyway, so it's not like it was okay and we're now making things worse. The point of doing this is so that people outside of the people that really understand this condition do take it seriously. They are willing to diagnose it, but they're also willing to diagnose the HSDs, which need the same management and treatment as hypermobile EDS. That's what's critical here. And the consortium and the society and every other charity's job is for us to educate that. So it's our job to make people understand that it's not less or more. It's not downgraded. It's not being put into something else. It's two different criteria, two different diagnoses, and both need the same attention, validation, management, and care. And so when we say at this time, we can't foresee a reason why people would be forced to be re-diagnosed. But if you go to a doctor and they choose to reevaluate you, that's not something we can predict or control. Also, if you want to enter into the registry, you will be reevaluated based on the new criteria, because that data is only as good as what you put in. So we've had to have a new criteria in order for us to make the data very, very good. So they're all the issues that we have. And I don't think people should be scared that if it does come to a point where they are reevaluated, that is a negative thing. If we do our job well, and we now have the tools to do it, then it will be seen as an equal thing and people will get what they need. Is there anything you want to add to that?
I agree.
Great. Okay. So this is an interesting question that's come up. Is it possible that you wouldn't get a diagnosis of hypermobile EDS at a young age, but then when you get older and you get more complications, you would get the diagnosis?
Yes, it is very possible because a young person may have generalized joint hypermobility without any of the musculoskeletal complications, and those may emerge over time.
Yeah. We're now back on live on Facebook. Sorry, the service has been dipping in and out, but just to remind everyone on Facebook that this webinar with all the questions is going to be available on our website later today. Okay. So were the neurological issues, this is from Blair, were the neurological issues that are related to EDS taken into consideration for any of these classifications? Yes, we have a neurology group that focused completely on all of these issues. But as we mentioned in the webinar, we have not included any of the comorbidities in the criteria. However, we have produced management and care guidelines because we're aware that they exist. We now need to prove the causation between these and prove the link so that we can then one day potentially include it in the criteria. Anything to add to that?
No, I agree. We just don't have enough information at this point to really say whether the presence of Chiari or tethered cord or basilar invagination, if any of those things are fundamentally related to the Ehlers-Danlos syndromes, if they're causally related, if it's a comorbidity. So we just need more information. We know we see them in patients who have these diagnoses, and it's very important for us to recognize that they may be present, to look for them, and to treat them appropriately. But we don't have enough information to consider them in the actual classification and diagnostic algorithm at this time.
Sorry, just having to read through everything. Okay, so for some time it has been plugged that hypermobile EDS is not rare. Will hypermobile EDS now be considered rare and HSD more common? So yes, you've heard me personally say many times, this is common, it's not rare, it's mis and undiagnosed. But the whole point of a mind is for it to change. You know, we have to change our minds based on the work that has been done. And by making the criteria stricter, less people will be diagnosed, and it will go back to living in the rare disease category, which is around 1 in 5,000. But we may do this registry, and we may actually find out it is much more common than that. We won't know. We don't know the figures yet. We do know that for sure HSD is going to be much more common and not a rare condition, but we can't state figures accurately. We can guess, but it's not helpful to anybody. We need to now prove, and now we have the tools to enable us to do that.
I just mentioned.
Yes. Can we add our charity to the Amazon Smile charity program? Yes, we actually are on there. We just need to do some things our end because of the switch we had between EDNF and the society, and we are working on that currently. So yes, thank you for that question, and please do add Amazon Smile. It's a really great way for you to help donate and support what we're doing. So is this nosology saying that JHS and hypermobile EDS are not the same thing? In past research, it has been said that they are the same thing. Yes, this is saying they are not the same thing. And what is replacing JHS is HSD. So we have had published papers, but things move on once work is done, and that was the point of this effort.
I think at the time when people were thinking that joint hypermobility syndrome and hypermobile EDS were one and the same, the diagnostic criteria for the hypermobile type of Ehlers-Danlos syndrome were not as well defined as they are going to be moving forward. And so under the understanding at that time, it certainly looked like hypermobile EDS and joint hypermobility syndrome were the same. But because of these new definitions, then we're able to separate them out.
Question just come through on Facebook from Jen. What do she saw you as a teen and was diagnosed with hypermobility. She's now pregnant with a daughter. What do I need to be aware of whilst pregnant? Are there any changes there on advice to pregnant women?
So I think I'd rather answer that question offline.
Yeah, no problem.
She can contact us directly, and I'd be happy to speak with her.
No problem. Is there a question here from Linda? Is there an umbrella term used to refer to the various EDS forms and the HSDs? No, there isn't. This is very new. One may come out. Who knows? As time goes on, but currently there is not an umbrella term.
I think our catchphrase Ehlers-Danlos syndromes and related disorders would be a good umbrella term.
Yes, and that's as close to an umbrella term as we have for now. Is there a way to get printed materials to distribute to the info to local health organizations? Yes, as I said, all of these documents are free to download on our website, and we want you to spread them as far and wide as you possibly can. Why is the Baton score being used when it was not intended to be used as medical diagnostic criteria?
Well, the Baton score has a very long history in the diagnosis of Ehlers-Danlos syndrome. And if you take a look at the paper, the committee that considered the Baton score did an enormous amount of work. I mean, it is really an incredible effort to review all of the literature on the diagnosis of joint hypermobility. And in the end, they felt that there really wasn't enough hard evidence to support including other joints into the diagnostic category that we think about for diagnosing generalized joint hypermobility, and that because it has been used so extensively, the Baton score in its current form is our best tool for now. But this is another one of those things that I think will certainly evolve over time. And many people recognize that by not including the shoulders, by not including the hips, by not including the craniocervical junction, we're omitting a lot of very important joints to consider in joint hypermobility.
So a question from Ellen. When the criteria says first degree relative is affected, does that mean within a specific type? I meet the classical EDS criteria. Multiple first degree relatives meet the hypermobile EDS criteria. And I guess with this answer, Claire, you can answer the question of can you have more than one type of EDS, which we get asked a lot.
Right. So usually we would expect to see within a single family the inheritance of a particular type, one particular type in a family. The classical EDS criteria actually changed over time. I would say, we really started to recognize that the extreme involvement of the skin is the definition that is going to correspond best with the finding of the type 5 collagen gene mutations. So if this person met the classical EDS criteria some years ago, they might not meet the classical EDS criteria under the current recommendations. So I think we would expect that the most likely thing is that within a certain family, within one family, the people with Ehlers-Danlos syndrome would all have the same type of Ehlers-Danlos syndrome.
So where can you get the papers to print? Rebecca and various people have asked. You can get them through our website, and they are free to download, and we encourage everybody to download them. I'd like to just add to Facebook as well and to the webinar. We are not in control of when the American Journal releases that link. The very moment that they do and the papers are available, we will have them on our website and everybody can view them. It's no interest of ours to hold it back from you whatsoever. So the very moment that it's available, you can view it on our website, and we will post on Facebook when that moment is, and it will be on very easy to see on the homepage of our website. So please be patient with us. You will get everything you need, including updated pages on our website, answering questions that we have preempted you may ask. And please, at any time, email info@ehlers-danlos.com, lara@ehlers-danlos.com, helpline@ehlers-danlos.com with any questions, concerns, or things that you think should be on our website that you would find really helpful that we haven't got on there yet. Help us. Let us know what would be helpful to you, because we are there for you. So Facebook as well, if you could do that too, that would be wonderful.
So the question is about the new musculocontractural Ehlers-Danlos syndrome. The person says that she tests positively genetically as well as the diagnostic criteria. I am not the expert on the musculocontractural type, and I'm not the best person to discuss this, but if you take a look at the paper on the rarer types, of which Dr. Malfate is the first author, you will see all the current state of knowledge about that.
Thank you. A question that's coming up in various forms is there a way to test for hypermobile EDS genetically or through blood tests? No. There is absolutely no other way other than clinical that you can test for hypermobile EDS at this stage. So no matter what doctors try and tease you with, or whatever papers you see out, or exciting promises. At this stage, there is absolutely no test for hypermobile EDS other than to be clinically diagnosed. Anything you want to add to that?
No.
Great. So I don't quite understand this question from Glenda. I don't quite understand how hypermobile EDS can be both underdiagnosed and overdiagnosed per a video on the Society's website. Honestly, it's unique. I believe that a lot of aspects of the EDS community are unique. But one area is that this is definitely both over and underdiagnosed. And what I mean by that is patients can't get to the doctors. They can't, wait on the waiting lists. So they're going to Dr. Google and they're making assumptions based on what they read online that they have the condition. And they are telling people that. And it might not be accurate. And so a lot of people are overdiagnosing themselves, and a lot of doctors are underdiagnosing the people that walk through the door. So you've got a mixed problem, which is what's caused such, confusion amongst the medical world and the patients. So what we're saying is stop diagnosing yourself and take the criteria papers to your doctors and demand that they use those to test you for this. That you have the right to do that. And these are internationally agreed papers that are now in place to help doctors use. It's criteria. It's not something that you have found on a forum or a charity's website. This is not produced by the Society or EDS UK or any of the other national organisations. This is produced by the International Consortium on EDS and Related Disorders. It is produced by medical professionals, patient experts that have all come together to work on this. So it's something that can be respected and used everywhere.
I would also add that the Villefranche criteria, because they were so non-specific, really contributed to the overdiagnosis of hypermobile Ehlers-Danlos syndrome, because you could be diagnosed with hypermobile EDS in the presence of simple joint hypermobility, generalized joint hypermobility, without any of the other features of the syndrome as it is currently being defined. So I think some medical professionals were overdiagnosing it as well. And just as Laura said, it led to really quite a lot of confusion and misinformation. So I really hope that this new diagnostic set of guidelines will really help to streamline things.
Okay, what kind of research is occurring on pain management? Now, we get this question a lot as a charity because we put out there that one of our biggest priorities is research. The problem is I genuinely have on my desk 4 or 5 research applications from people that are ready to go, and that includes the registry that will equate to a lot of research. The problem is funding. People don't realize how much it costs to carry out this work. So people might donate $5,000, $10,000, and that's wonderful, but it won't make a dent in the research that it costs to put on this kind of project. So the more money we have and the more that we can get grants and the more that we can seek donations to do the research, then the research will be done. We know we need to do research into pain management, all of the comorbidities, the links, the causations, the prevalence, defining the gene, building the registry. There is an abundance of research that needs to be done. We have all of the professionals ready in place, the labs to do it. We do not have the money. So we need to break out of the EDS community where we know that there's not a lot of money and make people outside care about this condition and realize that they will probably know someone that is affected by this and really try and increase the donations that are coming into the society who have taken responsibility to try and make this research happen. So what else do we have here? What about gastro problems? Are they now unrelated to EDS completely? Absolutely not. No comorbidities are unrelated to EDS. What we're saying is we can't prove the causation. In fact, Professor Aziz's team in the UK has probably gone the furthest to prove the relationship between GI and EDS, but we have yet to prove why. What is causing that link? And until we do, it can't be in the criteria. It is insane to me that people think we've ignored the comorbidities when we equip groups that were just, tasked with working out how to help people with these comorbidities to produce internationally agreed management and care guidelines. So even though it's not in the criteria, we're saying people with these symptoms, this is how you treat them. This is what we know. This is what we need to know. It's there for all of them: mast cell, neurology, GI, psychological, pain, physio. Baton, the list goes on. And for the next round, we're adding a pediatric group and a skin group. It will ever be increasing. Please don't think that we are neglecting the comorbidities. Quite the opposite. We are giving them a lot of attention and time. Question for you, Claire. Can you please elaborate on the atrophic scarring criteria for hypermobile EDS? How do you determine it is not like true atrophic scarring?
Well, I believe it is true atrophic scarring. They're widened scars. They used to be described as cigarette paper scars. So if you see a scar that's a thin line and it's healed well and the skin hasn't separated out, that's not an atrophic scar. Maybe we could put some pictures of what atrophic scarring looks like on the website.
We can do that.
To see.
We can do that. Another question that's come in from Deirdre. If a member of one house has diagnosed hypermobile EDS and a child in the same house has hypermobility spectrum disorders, what is the opinion of what is going on in this house?
I can answer that question.
Great.
So Dr. Castori particularly addresses this issue in his paper, and it is very possible that there will be children, one who meets the criteria for hypermobile Ehlers-Danlos syndrome and another who has generalized joint hypermobility, but no symptoms related to that generalized joint hypermobility, and that child may be diagnosed with the hypermobility spectrum disorder. And as we discussed earlier, as that child gets older, I mean, we hope not. We hope to develop strategies where people who are asymptomatic remain asymptomatic their whole lives and never need medical care for any of these comorbidities. But a child with hypermobility spectrum disorder may develop more symptoms as they get older and then may eventually meet the criteria for hypermobile Ehlers-Danlos syndrome. And again, because we don't know what the genetic underpinnings for these conditions are yet, we really can't say on a molecular level exactly what's going on. But our fervent hope, is that eventually we will have a molecular cause, a molecular test, and we'll be able to test that child with hypermobile EDS and the child with hypermobility spectrum disorder and say that they do or do not have the same alteration in their DNA that's leading to these findings in the connective tissue.
Thank you. Okay, so we have 10 more minutes, so we'll get through as many of these as we can. How does society prevent doctors in the community from disregarding HSD altogether due to the belief that it is simply a painless disorder that causes loose joints? There is no belief of anything, because up until today it didn't exist. So you're talking about joint hypermobility syndrome, and we have created the HSDs so that that term is no longer used, and that attitude and belief towards it also vanishes with it. The whole point of creating this paper and what Marco has written in it is HSDs can absolutely cause pain and all the comorbidities, and it is stated clearly in that. So if a doctor is diagnosing you with it, he needs to have read the paper, and in the paper it says that. So people can't make up their own belief of what something is. That's the whole point of having these internationally agreed papers, so that doctors can actually use them and rely on them.
Well, and also in the spectrum of joint hypermobility, there's the asymptomatic joint hypermobility, and then there's the hypermobility spectrum disorders. So the people with hypermobility spectrum disorders are specifically those who are experiencing symptoms related to the joint hypermobility. So in the definition of hypermobility spectrum disorders is the presence of symptoms. So anybody who is saying that these are asymptomatic conditions just hasn't read the paper.
Okay, can you speak to how skeletal deformities rather than musculoskeletal pain is factored to the diagnosis, for example, Marfanoid habitus?
So the Marfanoid habitus is considered within the diagnostic criteria for the hypermobile type of Ehlers-Danlos syndrome. That includes the arachnodactyly, which is the relatively long fingers, as well as the arm span to height ratio of greater than or equal to 1.05. In my belief, there's probably a subset of patients with the hypermobile type of Ehlers-Danlos syndrome who have Marfanoid habitus. Not everybody who has hypermobile Ehlers-Danlos syndrome has a Marfanoid habitus, but that's why in that list of criteria for the systemic involvement, we are able to pick 5. So not everyone will have every one of those criteria.
Thank you. Do you know the answer to that, or is that one that would be on the rarer?
So the question is, has any of the new research shown a link between the Ehlers-Danlos gene mutations and the MTHFR gene mutation? So certainly there's no research linking any of the gene mutations that we know of for the classical type and the vascular type with MTHFR gene alterations. And since we don't have a gene identified for the hypermobile type of Ehlers-Danlos syndrome, we really can't make a comment about that at this time. I will say that the MTHFR gene variants are extremely common in the general population, so we would expect them to be extremely common among the patients with Ehlers-Danlos syndromes.
Quite a quick question. When do you expect the ICD-10 codes to be changed? Impossible to say. We don't know how long that process will take. All we can say is we are working on it. Question, is this the end of so-called crossover types? I'm not sure there ever were officially crossover types, but yes, you cannot have more than one type of EDS. I'll let the medical professional elaborate again on that, but we can't seem to say it enough.
So I think in the days when we were kind of switching between types 1, 2, and 3 and the classical and hypermobile type, people felt like there was that type 2 with minimal skin involvement, or maybe a little bit more skin involvement than we usually see in the hypermobile type, might have been considered a crossover type. There are also connective tissue conditions that seem to have features of Ehlers-Danlos syndrome and other connective tissue disorders like Stickler syndrome and osteogenesis imperfecta. And I believe we have much more molecular information now, and that crossover label is not appropriate anymore.
Okay, one question. Dr. Frankenmeier, if you read that out.
So Tanya is writing, are Tarlov cysts common in EDS patients? And the Tarlov cysts are cysts in the neuraxis. They represent an expansion of the dural sac and the development of a cystic formation in the dura. And they are relatively common in Ehlers-Danlos syndrome patients. They can cause a lot of neurologic symptoms. And that is one of the specific neurologic conditions that is discussed in the paper on neurology and neurosurgical complications.
Somebody has asked about the, I think they mean Tenaxin X variation.
Mm-hmm.
So you can elaborate a bit about that.
So there's a gene called Tenaxin X that has been identified as causing a very, very small percentage of patients who carried a diagnosis of hypermobile Ehlers-Danlos syndrome in the past. And it was like less than 5% of patients with, when a population of patients with hypermobile EDS were evaluated, less than 5% of them had alterations in the Tenaxin X gene. So those patients, we're going to now need to look and see, do they meet the diagnostic criteria, the new diagnostic criteria that have been put forth for hypermobile Ehlers-Danlos syndrome, or as we go forward looking at patients with Tenaxin XB mutations, is there going to be a new set of diagnostic criteria that we need to develop specifically for those patients who have been molecularly defined?
Okay, well, it's 11 a.m. and I think we've reached the end. We kept cutting off on Facebook, so I'm sorry. Sorry to everyone there, but I'd like to say to Facebook and to the webinar that this will be available on our website later today with all of the slides, all of the questions, and everything that we spoke through at the beginning. As soon as we have the link from the journal, it will be available to download on our website for free. We will be putting links and directions for people across all our social media platforms and on our website. And please continue to send in questions to info at or helpline at or Lara at, whichever you want. And we will, as a team, try and get back to you. As you know, it's a busy time. We have our press conference tomorrow, where we hope to get this message out to the wider world. And it's a very exciting time. And I would again like to reiterate that this is not a time for fear or panic. This is a time to be positive and to have faith that the best is being done to get everyone managed, treated and validated so that we can all have the quality of life that we deserve. I'd like to say a big, big thank you to all of the members of the International Consortium. We would not have been able to do this without you giving up a lot of your free time, covering your expenses to fly around the world to do this and have meetings, cancel clinics and do all the things that you have done to enable this to happen. Thank you to all the team at the Society for helping us get to today, and for all the other national charities that have supported this and the work going forward. So thank you to everyone. Thank you to everyone at Facebook for joining us. And everyone, we had over 1,000 people joining us on the webinar. It's really amazing. And it's our time.
Thanks so much, everyone.
Thank you.
Bye-bye now.
Bye-bye.